Hi, my name is Michael Dougan. I am an associate professor of medicine in the Division of Gastroenterology at Mass General Hospital, and I am going to talk to you today about the GI complications from cancer immunotherapy. Here are my disclosures, none of which are directly relevant to my talk today. I do want to emphasize that I will be talking about some non-FDA approved indications for infliximab, vedolizumab, and JAK inhibitors. The learning objectives for today are to understand the prevalence of GI inflammatory toxicities from immunotherapy and the relationship to specific immunotherapies that we use, understand the differential diagnosis and initial workup for a patient with diarrhea on immunotherapy, understand the role of endoscopy in the diagnosis of checkpoint colitis, and to understand the management of confirmed checkpoint colitis and the role of biologic therapies in this treatment. I'm going to start with a case, which is a 78-year-old man with BRAF mutant metastatic melanoma. He was initially diagnosed in 1992 and had his primary resected from his back. He recurred with metastatic disease 8 years later. At that point, he had one tumor in his lung, and it was treated with a pulmonary wedge resection. 7 years after that, he recurred again with an enlarged inguinal lymph node that proved to have metastatic disease within it, and he was treated with local radiation therapy. And then it was another 6 years before he presented with widely metastatic disease, now with multiple pulmonary metastases. This is the first time he was treated with systemic therapy. At that point, he was enrolled in a clinical trial combining a BRAF inhibitor with a MEK inhibitor and an inhibitor of BCL2. He did very well on that treatment for 2 years, but then ultimately progressed in 2015. Fortunately for him, by 2015, we had access to immunotherapy. And before I go into it exactly how he was treated, I want to take a step back and just talk a little bit about how these treatments work. So as I'm sure you know, T cells are activated by two signals. The first of these signals is a signal for specificity. So that's the T cell receptor recognizing an antigenic peptide in the context of the major histocompatibility complex, or MHC. And in the case of a tumor, that is a T cell recognizing usually a mutated tumor peptide. So that's how the T cell knows that that particular target is not normal healthy tissue. But a T cell, a naive T cell, needs a second signal in order to become fully activated. That second signal is a signal for danger, and that comes through the co-stimulatory proteins CD80 and CD86, which then bind to the co-stimulatory receptor on T cells, CD28. And we now know that that two-step activation process for T cells is actually a lot more complicated in reality, that there are multiple additional signals, other co-stimulatory receptors and co-inhibitory receptors that modulate that initial signaling response. And two of those pathways, the CTLA-4 pathway and the PD-1, PD-L1 pathway, are depicted here in this picture. Both of those pathways act to downregulate T cell activation. And the reason why I'm highlighting them here is that these are the targets of most of our immunotherapies. So we have developed drugs that block CTLA-4, PD-1, or PD-L1, and then actually more recently a related receptor, LAG-3. And when we block these regulatory receptors, we get enhanced T cell activation, and many T cells that otherwise would not have become activated and are able to go after their target. And this has been really a transformative set of therapies for oncology. I'm showing you some of the initial trials on the left for a CTLA-4 inhibitor, on the right for a PD-1 inhibitor in metastatic melanoma. And you can see that these drugs really are considerably better, especially in terms of long-term survival, than what we had available before. And just to put some numbers to that, the current metastatic melanoma 3-year survival is about 40% compared to less than 5% before these drugs were released in 2011. And immunotherapy is now approved for the treatment of dozens of different cancer indications. So what happened with our patient? He was enrolled in a combination immunotherapy trial. So he went on ipilimumab and nivolumab, a CTLA-4 and a PD-1 inhibitor. 1 week later, he came to us oncology clinic and he was having diarrhea, 3 to 4 bowel movements a day. And he was treated at that point just symptomatically with loperamide. He then had a second cycle of therapy. And at that point, he started to get much worse. And by a week after receiving cycle 2, he was in his oncology clinic with severe cramping, non-bloody diarrhea that was coming 10 to 15 times a day, or had come 10 to 15 times over the past 24 hours. That was severe enough that he was admitted to the hospital. He had infectious studies sent that were negative, and then he underwent an urgent colonoscopy. And this is his colon. And this is what we call immune checkpoint inhibitor, or ICI colitis. It's sometimes called checkpoint colitis for short. And this is a life-threatening case. The symptoms of this colitis are generally watery diarrhea. Bleeding is less common than what we see with IBD. It does occur in some cases. Most of these patients have quite a bit of urgency. Pain and cramping is less common than urgency. And many of these patients also have accompanying nausea and vomiting. In terms of severity, we tend to grade this toxicity based on the number of bowel movements that patients have. These are CTCAE criteria that are used in clinical trials, so common terminology for criteria for adverse events. And this is a 4-point scale. Number 5 is that patients die from the toxicity. This is a very useful way of quantifying for the purposes of a clinical trial, but there are some limitations. So it does gloss over a lot of the diversity of these toxicities. It unfortunately does not accurately predict the outcome of treatment. So a grade 3 toxicity is not necessarily any harder to treat than a grade 1 toxicity. And unfortunately, it also oversimplifies a lot of very important biological distinctions that we know we need to care about. For example, if someone has diarrhea from celiac disease, it's very different than diarrhea that's being caused by a complication of a metastatic tumor. So when we block these receptors, CTLA-4, PD-1, PD-L1, we can actually get inflammation in any organ system in the body. So this is just a list of highlighting some of the common toxicities. In bold are common toxicities for either PD-1 blockade on the left or CTLA-4 blockade on the right. The management of these toxicities is tricky. And the reason for that is that we need to minimize the morbidity and mortality from them without inhibiting anti-tumor immunity. This is something that's tricky because any kind of immunosuppressive can hit the anti-tumor response. And so it does require us to leverage treatments whenever possible that can avoid systemic corticosteroids. It means that we have to find ways of using concurrent therapies that will allow for our patients to continue on their immunotherapy. And in the case of high-risk patients, such as those with inflammatory bowel disease, careful pretreatment assessments. I don't have to convince this audience that the gut is the most immunologically complex barrier in the body. It has to be able to tolerate dietary proteins and commensal bacteria to ignore these non-threatening, non-self substances, while at the same time continuing to defend us against pathogenic microorganisms and inhibit toxins. So it's not really a surprise that when we inhibit key regulatory mechanisms in the immune system, we get a lot of GI toxicities. And I'm just highlighting here a list of common toxicities that are listed either based on symptoms or pathologic diagnoses. The most common are enterocolitis, hepatitis, and pancreatitis. There are some rare toxicities, for example, isolated gastritis, cholangitis, and celiac disease. I will point out, because if you look at the clinical trials, diarrhea and colitis are usually listed separately. They really are the same pathologic process, but are graded differently and are placed differently on these toxicity charts based on the specific symptoms that patients have. I would also like to point out that if you look at what happens when patients get combination therapy, toxicities are dramatically more common than they are when patients get single agent therapy. It turns out that more than half of patients who get combination immunotherapy end up having to stop their treatment because of a severe toxicity. So talking back about checkpoint colitis again, enterocolitis is the most common GI toxicity from our current immunotherapy drugs. It generally presents as diarrhea, and it is in fact the most common cause of diarrhea in these patients. It has a range of severities. It can be an indolent, bothersome disease, but it can also be something that is immediately life-threatening. And while it is often isolated to the colon, it can involve the entire GI tract from the stomach to the colon. The presentation of colitis from the different drug classes that we have is slightly different. So when we block CTLA-4 with ipilimumab, colitis is more frequent and more frequently severe. It has a more rapid onset. It is definitely dose dependent. More ipilimumab increases the risk and severity of colitis. And when it's appropriately treated, it rapidly resolves. For PD-1 blockade colitis, it's more likely to be a microscopic colitis. It is more likely to have an indolent course. It's not clearly dose dependent, and it is slower to resolve once it is set in. I will point out that for the dose independence, we use anti-PD-1 therapies at doses far above the saturation point for the receptor. So that may be why it appears to be dose independent. We're just starting to learn about LAG-3 PD-1 combination colitis. For right now, it really does seem like it's very similar to colitis through the other pathways. It's probably more frequent than with PD-1 blockade alone, but I really have not observed any qualitative differences in this colitis compared to colitis from other pathways. There is a variable pattern in what part of the GI tract is actually affected by immunotherapy. These are data from Mass General Hospital looking at 80 consecutive patients with melanoma who referred to GI for possible checkpoint colitis. And they underwent EGD and flexible sigmoidoscopy or colonoscopy. And I'll start by just saying, 80% of them did have mucosal inflammation. You can see that up here, which means 20% of them actually had no inflammation in their GI tract. They had another cause of diarrhea. If we then look at the ones who had inflammation, 70% of them had colitis. But 10% of them almost had enterocolitis, so involving the small intestine and the colon. And nearly 20% of them had isolated disease in the upper GI tract. So this is a picture of checkpoint enteritis. This is a patient with checkpoint gastritis. Mild gastritis is actually fairly common from these drugs, but severe gastritis like this is not. And gastritis alone with no other GI tract involvement is also not particularly common. So how do we work up these patients? Well, the first piece of any medical workup is always history. We're asking patients about upper or lower GI symptoms, other medications that might also cause diarrhea, such as antibiotics or targeted or chemotherapies, any infectious exposures. And then we do want to know what immunotherapy they're on. We were much more concerned about colitis in a patient on a CTLA-4 inhibitor. For labs, these patients should be getting stool cultures. We should be sending C. diff toxin testing. Depending on their exposure history, ova and parasite testing may be appropriate. I advocate getting celiac serologies on all of these patients. They probably do have thyroid testing, but because these drugs can affect the endocrine system, that's something we always want to check. And then we can consider a calprotectin or a lactoferrin, depending on how quickly we'll be able to get them into endoscopic evaluation. So what do we do about endoscopy? The role of endoscopy in these patients is really to determine the severity and extent of inflammation. So we have been using a modified version of the endoscopic Mayo endoscopic score. This scoring system is a 4-point score. 0 is a normal appearing colon. 1 is erythema and edema. 2 is either marked erythema or mucosal breaks, erosions, which you can see here. And then frank ulceration of the colon or spontaneous bleeding is a Mayo endoscopic score of 3. We have found this to be very useful, as I will discuss later. The other piece of the endoscopy is really for diagnostic accuracy. As I mentioned before, only 80% of our suspected cases actually turn out to be enterocolitis, and we do want to find those patients who do not have mucosal involvement with inflammation. There is data out of MD Anderson that therapy guided by the information from endoscopy may reduce steroid dose and lead to faster symptom improvement. We do not know if all of this additional workup, though, affects tumor outcome. So who should we consider for endoscopy? Anyone with severe diarrhea, so grade 3 or 4, or anyone who's sick enough to be in the hospital. I also advocate using endoscopy in patients with persistent grade 2 or sometimes even grade 1 disease. And when available, endoscopy can be very useful for pre-steroid evaluation of patients, again, to find those patients who won't likely benefit from steroids, so you don't have to expose them to the steroids. Any patient with atypical symptoms, so a lot of bleeding, a lot of pain, fevers, patients with atypical onset, so coming after they've stopped immunotherapy or within the first week of treatment, or patients whose symptoms are rapidly changing. And then, of course, any patient who's on an investigational combination should go through a more thorough evaluation. That's really more something to worry about at tertiary care hospitals, but is still something that we definitely need to keep in mind. So what type of endoscopic exam is sufficient? A flexible sigmoidoscopy is generally sufficient in this patient population. We know that from a series that looked at where inflammation is likely to be within the colon, and in these patients, 95% of the time you can detect inflammation on the left side of the colon. EGD is what I would do as the next test if a flexible sigmoidoscopy is negative, because 20% of these patients will have inflammation only in the upper GI tract. What about diagnostic imaging? So by CT scan, inflammation from checkpoint blockade looks like any other kind of colitis or enteritis. It's generally a pancolitis or a segmental colitis, but the diagnostic accuracy is very low for this test. So the sensitivity is 50%, specificity 74%, positive predictive value 73%, negative predictive value 52%. So really CT scans are only helpful when you have an atypical presentation and you're worried about extraluminal complications of a checkpoint blockade toxicity. So what about the relationship to inflammatory bowel disease? And superficially, checkpoint colitis does look like inflammatory bowel disease, more similar to ulcerative colitis than Crohn's disease. It's often a pancolitis. Deep ulcers and strictures can occur, but they are less common than superficial ulceration. Fistulas do not seem to occur in these patients. Most of them have a monophasic course. So once you treat the colitis, it goes away. But cases of new onset IBD have been reported after ICI therapy, or at least what looks like new onset IBD, a relapsing, remitting inflammatory disease of the GI tract. So what happens when someone with IBD receives checkpoint blockade? So there's another case, 74-year-old man with Crohn's disease. He had been off medications for many years with no symptoms. He developed metastatic sarcoma. He was treated with nivolumab anti-PD-1 therapy in early 2017. 2 weeks after his first dose, he came to the ED with left lower quadrant pain. Pain's not common as a side effect from these drugs, so he underwent a diagnostic CT and was found to have a perforation in the ileocecal region. He received steroids and antibiotics. Nivolumab was held. He had a complete ileocecal resection with no further complications. He subsequently completed an immunotherapy course and remained in remission actually for 6 years before he eventually died from complications of prior radiation therapy. So overall, had a very, very good response to treatment, otherwise really a refractory tumor type. So this is one case. How representative of general patients with IBD is this? To answer that, we entered into a 14-center collaboration with more than 100 patients with IBD. This group mostly comprised patients with melanoma and lung cancer, the two most common indications for ICI therapy at that time. And most of the patients were on PD-1 blockade. Again, that's the most common immunotherapy used. If we look at their IBD, they were evenly split, Crohn's disease and ulcerative colitis, but most of them were off therapy and asymptomatic. So this compares to national percentages of about 25%. Here, half of them were off therapy completely. That's That's really unusual and suggests some selection bias for patients with mild IBD. This is all retrospective data, and so selection bias is something we really need to think about. Even though these patients probably did have unusually mild IBD, they had a very high GI adverse event rate. So 41% of these patients developed a GI adverse event compared to 11% in a non-IBD control cohort in the study. 21% of these patients had a serious adverse event, which did include perforation, such as what I showed you. But none of the GI adverse events were fatal. Cancer-specific mortality was similar to published trials. What does this mean? It means that these patients really can be treated with immunotherapy. We just have to watch them carefully, be on the lookout for severe complications, but overall, they're likely to benefit if we do treat them. So what are the lessons from this? IBD should not be a contraindication to ICI therapy. Gastroenterologists should be involved from the beginning of their treatment course, though. Prior IBD medication should be continued. Recent endoscopic assessment, I say within about 3 months, is reasonable. Have a high suspicion for serious complications. And IBD flares during ICI therapy are often, they often occur, and they're often hard to treat. And oftentimes afterwards, after they've finished immunotherapy, their IBD is harder to treat than it ever was in the past. And it is something that I do counsel patients about. So how do we treat general checkpoint colitis? And I'll say right now we have no prospective high-quality data on this. So most of what I'm going to tell you is from retrospective data or expert opinions. First-line therapy is high-dose systemic glucocorticoids. So in our patient, he received IV steroids and then was discharged from the hospital after 3 days on prednisone 60. He represented to Mass General only a few days after discharge with recurrent symptoms despite being on prednisone 60. He was restarted on IV steroids with a prompt response. So what is the standard steroid treatment for these patients? Right now, we typically use doses of 0.5 to 2 milligrams per kilogram, often in divided doses when it's given IV, or as a single daily dose when it's given as oral prednisone. Again, no rigorous studies of appropriate steroid dose, and roughly 70% of patients will respond to this treatment. The treatment algorithm that I use is for inpatients. I give them 1 milligram per kilogram twice a day of IV Solu-Medrol or equivalent until symptoms resolve. Then I transition them to prednisone 60 milligrams PO afterwards. For outpatients, I start them on 60 milligrams of prednisone. The taper I make based on the mucosal severity, typically dropping every 5 to 7 days and decreased by 5 to 10 milligrams a day of prednisone or a prednisone equivalent. And these guidelines can actually be found, or these recommendations can be found in a clinical practice update in gastroenterology, and that was published a couple of years ago. So I've already mentioned a few times that systemic steroids might be a problem in these patients, and I'll just show you some of the data to give you some pause. So this is the first study to really look at steroids in this patient population, and what they found, this all retrospective data out of MD Anderson, they looked at patients who had toxicities compared to those who didn't, and they can see that the overall survival in these patients or time to treatment failure was very similar. If you then look at the patients who received steroids compared to those who didn't, again, time to treatment failure was very similar. The problem with this is that patients only received steroids if they had an adverse event. Anyone with a serious adverse event was likely to get steroids, and we really don't know if there's an immunologic connection between the likelihood of getting an adverse event and the likelihood of responding to treatment in terms of the cancer. It's possible the steroids are masking this benefit. And just to show you what that would mean, maybe that yellow line could have been way up here. Those are the patients with synergistic effects, toxicity and fighting their cancer. We gave them steroids and maybe dropped down the benefit. And there is data to support this. So this is from a colleague of mine, Alexander Faji, who looked at patients with metastatic melanoma on CTLA-4 blockade who developed hypophysitis. And what Alex did is he took advantage of the fact that patients with hypophysitis at the time of this study were treated with one of 2 treatment protocols, either low-dose steroids to rescue only the adrenocortical axis or high-dose steroids to try to actually suppress the inflammation. Nobody knew which strategy was better, and so different doctors picked different strategies. It turns out high-dose steroids was associated with much worse overall survival and time to treatment failure. And this is an oncologic death, that patients had their tumors progress, not dying from lymphocytitis. I will point out that the patients on high-dose steroids did about as well as you would expect for someone on ipilimumab, 15 to 20% long-term survival. It was the low-dose steroid patients who did much better, compatible with this synergistic toxicity anti-tumor response model. So can we predict who is going to respond to steroids? Symptom severity does not correlate with response to steroids. Something very important to emphasize that includes diarrhea frequency, pain, bleeding. What does correlate is the Mayo endoscopic score. So the worse the inflammation, the more likely they are to need something in addition to steroids. Colonic ulcers are a strong predictor of steroid response. If they have ulcers, they are less likely to respond. Enteritis may also predict a worse steroid response. There is no association between the likelihood of responding to steroids and the type of immunotherapy used. So if a patient doesn't respond to steroids, what are our options? TNF inhibitors, specifically infliximab, have been used successfully in many patients. In ipilimumab colitis, we typically see responses after one dose and within a few days, although in general, I finished the entire loading dose series for biologic therapies in these patients. Unlike IBD, most of these patients will actually have gut homeostasis restored and will not recur. So in our patient, he responded to steroids, but then we gave him infliximab. He was successfully discharged and was able to completely come off of steroids after just one dose of infliximab. What if he hadn't responded? So vedolizumab is also very effective in this population. Does seem to act more slowly than with infliximab. It should not interfere with anti-tumor immunity, which is a good strength of it. It really is just a gut-specific drug, but I would avoid it in patients with primary GI malignancies or GI metastases. So what if they don't respond to either of those drugs? We don't have a good answer to that. Some of these cases are infectious. We should look for that by endoscopy. Other treatment options. Ustekinumab has been looked at, and it does seem to be effective. JAK inhibitors, specifically tofacitinib, has been looked at, seems to work. Other options, CTLA-4 Ig, surgery for isolated colitis, though that's rarely what we should be doing. Other cytokine inhibitors like IL-1 beta or IL-6 inhibitors could be considered, and FMT has also been looked at. What does not work is bowel rest. I'll just emphasize that JAK inhibitors do appear to be very effective in life-threatening cases of checkpoint colitis. They're also very likely to interfere with anti-tumor immunity and should be reserved for patients with severe life-threatening toxicities. What if we want to restart immunotherapy after a toxicity? That is also something we can do. If you restart immunotherapy with infliximab or vedolizumab on board, it does appear to decrease the risk of recurrent severe colitis by about 70%. So I just have a couple of quick cases here. This is a patient on pembrolizumab, PD-1 blockade with pulmonary adenocarcinoma, came in with diarrhea and weight loss. We did an upper and lower scope. The upper scope showed celiac disease. We were able to verify that with serologies. Overall, this has about a 1 to 2% prevalence in these populations. This is new onset or newly symptomatic celiac disease. It does respond to a gluten-free diet, typically does not need steroids. Immunotherapy can be continued. Another important case, 62-year-old on PD-1 blockade with resected melanoma, also came in with diarrhea and weight loss. This patient on scope had no visible inflammation, but microscopic colitis. This responded to budesonide. Many other patients will also respond to budesonide when they have microscopic colitis like this. In these patients, they can stay on concurrent budesonide, do not need systemic steroids, and they do not need to stop immunotherapy. So final take-home points, patients on immunotherapy with severe diarrhea may have colitis, but celiac disease, microscopic colitis, and complications from malignancy should be considered. Symptoms do not accurately predict mucosal severity or response to systemic steroids in these patients. Endoscopy can be useful for risk stratification and for identifying patients who do not need systemic steroids, such as those with microscopic colitis. Most ICI colitis responds to systemic steroids, about 2/3 of cases, but secondary immunosuppressive options include infliximab and vedolizumab. Microscopic colitis from immunotherapy can respond to budesonide. ICIs can be used in patients with underlying IBD, but careful monitoring is important, and steroids may limit the treatment effect of ICIs. Thank you for your attention.